Hello, my name is Awad Khan. I'm a resident at the University of Central Florida College of Medicine at the North Florida Regional Medical Center Internal Medicine Residency Program. Today I will be talking about a case report titled Takotsubo Syndrome likely induced by ischemic colitis and complicated by superior mesenteric artery occlusion. I'll be brief with the case so I can talk about the discussion and conclusion. The case goes, you have an 82-year-old female. She presents for evaluation of hematemesis, acute and chronic abdominal pain, and new onset chest pain. Physical exam was remarkable for some diffuse abdominal tenderness. Labs revealed some mild leukocytosis and chronic anemia. Given this finding of at least the chest pain, we wanted to rule out acute coronary syndrome. Initial troponins were minimally elevated, and EKG was unremarkable for a true STEMI. So we ordered a transthoracic echocardiogram. If you look at figures 1A and 1B, you will see that you're looking at an apical four-chamber view of the heart. 1A demonstrates complete systole of the left atrium and ventricle compared to 1B, which shows complete diastole and relaxation. These are still images, so it's very difficult to see that there's actually also some akinesia generally all around the heart, but most prominently at the apex of the heart. Ejection fraction also revealed to be 35 to 40%. Given these findings of the echo, as well as just the lack of focal wall motion abnormalities, troponin trending flat, unimpressive EKG, and recent heart cath in her history, it was deemed that these findings were inconsistent with typical ACS and more suggestive of Takotsubo syndrome. So now we have to figure out the cause for this. Essentially, the patient continued to have abdominal pain, so we explored that with a CT abdomen and pelvis, which revealed some subacute inflammation. We then did a colonoscopy, which revealed massive inflammation throughout her colon, more prominently at the cecum and the ascending colon. You can see from figures 2A and 2B, inflammation, edema, ulcerations all throughout the colon, which were very consistent with ischemic colitis. This patient, however, ended up developing superior mesenteric artery occlusion and died in the next few days. So what's going on here? This is Takotsubo syndrome, previously known as Takotsubo cardiomyopathy. Now Takotsubo syndrome is the recognized unifying term. And what it is myocardial dyskinesia of the left ventricle and apical ballooning in the absence of myocardial infarction. Takotsubo syndrome presents very similar to ACS, so the way to diagnose is to essentially rule out ACS. The Mayo Clinical Diagnostic Criteria is the most commonly used diagnostic criteria. Essentially, you're looking at four things: early electrocardiograms, cardiac troponin levels, coronary angiogram, and as well as serial assessment of the left ventricle via an echo. There is no universal accepted diagnostic criteria. However, the Mayo Clinical Diagnostic Criteria is the most commonly used. And also certain studies have said that whereas you don't necessarily need all the specific criteria to diagnose TTS, you can use it via a strong predictive value as well. Researchers have suggested that the mechanism behind Takotsubo syndrome is transient catecholamine release under stressful situations, which lead to myocardial dysfunction because of all the catecholamines. Essentially, in our patient, it was the inciting inflammation due to ischemic colitis that led to the essentially transient catecholamine release, which ended up causing damage to the myocardium, leading to Takotsubo syndrome. Essentially, our approach to this patient aimed at balancing the management of the cardiac and GI pathologies. This patient had hypovolemia secondary to acute blood loss and volume loss, which may have precipitated the ischemic bowel changes, which ultimately led to elevation of adrenergic levels and catecholamines to a point thereby inciting malfunction of the myocardium and ultimately leading to TTS. You can see that in figure 3, that progression. This is also the progression that is suggested in various other case reports and various other studies looking at the mechanism behind Takotsubo syndrome. Not many studies have actually mentioned GI causes leading to Takotsubo syndrome. A few case studies have, and a couple studies have actually noted ischemic colitis as an etiology as well. Lastly, this case report is very important because it allows physicians to be aware of the rare triggers and etiologies that lead to Takotsubo syndrome. And it is important for us as physicians to be able to understand the various unique etiologies and be able to address Takotsubo syndrome before it can cause severe damage. Thank you so much.